The next speaker الحقيقة one of the eminent speakers and eminent professors in pediatrics and neonatologists, not only in Emirates but in all pan-Arab countries and the Middle East. Professor Khaled El-Atawi واحد الحقيقة من الناس اللي احنا في مصر كلنا بنكن له كل إعزاز وتقدير. بليز دكتور خالد اتفضل.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, for this kind introduction. طبعا أنا أحب أشكر أستاذي أستاذ دكتور ثروت دراز، وأنا طبعا في موقف صعب إن أنا أتكلم بعد أستاذي، فده بيعمل لي شوية tension، it is out of my comfort zone. وأشكر أخويا الدكتور إيهاب خيري، دكتورة إيمان فودة والدكتورة مي نصار على الدعوة الكريمة. I'll be speaking today about the bundle in the necrotizing enterocolitis in the NICU. I have nothing to disclose. I'm working in a tertiary center with around 6,000 deliveries per year, with 64 bedded into ICU. 25% of them are preterm, and 70% of those preterm are late preterm babies. We are having the nitric oxide, and now we are having a conjoint with the Center for Cardiac Surgery. So we are level 4 care as per the Vermont Oxford network, and we deal as low as 450 grams babies. So my objective for this talk is the necrotizing enterocolitis. I will introduce it in a new way with a new vision, with the pathophysiology, risk factors, and clinical presentation. I'll be speaking about the bundle and how bundle improve the care in the neonatal intensive care units, and how we will use this bundle for the necrotizing enterocolitis. I usually like to start by asking questions. So the first question is, we are having 23 weekers, preterm baby, 560 grams, intubated, received Cervanta, extubated the third day on non-invasive ventilation. As the baby was stable, trophic feed was started on day 2 with EBM, expressed breast milk. Do you approve this practice? Who approves? Okay. The second case is 24 weekers, 650 grams, respiratory distress, mechanically ventilated, oxygen 70%, pressures 20/6. He is on dopamine because of low blood pressure. Do you approve the opinion of starting trophic feed? Yes or no? Yes. Late preterm, 34 weekers, born by cesarean section, severe fetal distress, admitted to NICU with tachypnea, new blend, 3 liters, Apgar score 3 and 5 at 1 and 5 minutes respectively. pH is 7.2, bicarb is 13. Baby was fed 20 ml formula on day 1. Do you approve this practice? Who will approve? Who? No. Okay. Why أخاف؟ عشان الصورة دي. This is the cause. We are afraid of this picture. Okay. This is the nightmare of any neonatologist. This is what we can land with: severe necrotizing entero or pan necrotizing enterocolitis. So as you can see here, this is the classification. This is the X-ray pictures. You can see the air under diaphragm in the first picture here, and you can see the cannonball sign in the picture on the lower left side. So Richard Pullen mentioned in the early 2000s that caring for premature babies with necrotizing enterocolitis is exactly as if we are having a roller coaster with a very high speed, and there we are, we cannot know or we cannot predict what is next. So the question is, necrotizing enterocolitis is a common problem in our practice or no? Let's take it through the epidemiology, the scope of the problem. It is a big problem because the burden is for the extreme preterm babies ranging between 22 to 28 weekers with incidence of 7 to 13% nationwide over the last 2 decades. The survival, even after the necrotizing enterocolitis, are having long-term complications and short gut syndrome. It is very costly to the community, costly to the parents themselves, and costly for the country as well. So, and it is scaring for all the neonatologists. So what we knew earlier, that necrotizing enterocolitis was only for preterm babies. Now the necrotizing enterocolitis is subclassified into different disease, as you can see here, starting from the SIP, which is the spontaneous intestinal perforation, and this occurs either in term or preterm babies as early as the first 10 days. And then comes the preterm necrotizing enterocolitis, and this what we knew earlier about the necrotizing enterocolitis. But what is new now is we are having a term necrotizing enterocolitis. We are having a septic ileus, which can mimic the necrotizing enterocolitis, and we are having feeding intolerance that can also mimic the necrotizing enterocolitis. So the new necrotizing enterocolitis is not the same that we knew earlier. So the pathophysiology is the more the premature, the later the onset. The hypothesis for pathogenesis is still vague, as we mentioned, and as we will come to know in a while. It is a multifactorial, starting even from before birth, when we are giving to the mom the antibiotics, long-term antibiotics for the moms. The current understanding suggests that developments occur due to imbalance between the hyper pro-inflammatory signaling in the mucosa of premature babies with the dysregulation of the gut microbiota. This will lead to the injury of the premature epithelial cells. This process will decrease in the intestinal perfusion, and on top, when we will have a bacterial invasion, this will lead to intestinal death of the intestinal tissues, as well as possibility for the bowel perforation. So in the recent years, several primary risk factors have become apparent, and it is the most important of them is the premature intestinal mucosa, the gut ischemia, and that's why, if you remember, we were worried to give the feeding for the baby who would have a low Apgar score. So gut ischemia can be a cause, and not only from the ischemia from the birth, it can be ischemia due to congenital heart disease affecting the perfusion of the gut. The microbiome dysfunction, as we discussed, and the bovine derived enteral feeding, such as the formula feeding, can lead to this disease. Most important that we are having a predisposition due to genetic factors. So we should keep in mind that the necrotizing enterocolitis of prematurity is a multifactorial, and we should work on all the factors together. As I told you, it is starting from birth, prenatally even related to maternal diet, chorioamnionitis, and use of the antibiotic. All these factors, the birth history, which is the cesarean section, most important, and the use of antibiotics, using of the formula feeding versus the breastfeeding, using of prolonged antibiotic inside the NICU, all these will lead to either short-term effect for the baby in the form of necrotizing enterocolitis, sepsis, or increased risk of chronic lung disease, or the long-term effect like the asthma, allergies, and obesity. So what is the characteristics of the intestinal mucosa of premature babies? It includes the epithelial bathing of the inside the amniotic fluid, which is abundant with the growth factors. This will help the development of the epithelium in the preterm babies. The important barriers between the bacterial intestinal flora and access to the underlying vulnerable mucosal layer. The tight junction between the epithelial cells is the main stay that will prevent the development of the necrotizing enterocolitis. If this tight junction is disturbed, we will have increased permeability and inflammation, malabsorption, and more leakage, leading to epithelial injury and necrotizing enterocolitis. In addition, we are having decreased in the acid secretion of those preterm babies, and most important, the decrease in the peristalsis. This decrease also in the goblet cells that will produce the adequate mucosa that will give protective layers over the epithelium. Most important, now we are having the Paneth cells that will secrete the antimicrobial factors and the immune modulating proteins. This will control the intestinal microbiome and regulating the gut homeostasis. So what happens after birth? We are having the perinatal period, whether it is cesarean section or the prolonged hospitalization or prolonged use of antibiotics or formula feeding. This will negatively affect the mucosa and decrease the amount of lactobacilli and bifidobacteria and increasing the amount of Clostridium. The perinatal antibiotics also can cause intestinal dysbiosis and will lead to increase in the short-term and long-term effect on the babies. As we mentioned, we are having different factors, multifactorial, that will cause a gut dysbiosis, and the gut dysbiosis will lead to, in the very low birth weight infant, can lead to necrotizing enterocolitis, late onset sepsis, and death, while in all neonate can increase the bowel, inflammatory bowel disease, obesity, and wheezing. I'm having a question now. Is this disease affecting the full-term babies? And yes, if yes, is there any difference between the picture in preterm and full-term babies? Yes, it is affecting the preterm babies more than the term babies. It is up to 90% in the preterm babies, but we are having 10% in term babies. So we should take care of this number of the 10%. The incidence in term, it is 1 over 20,000%. The risk factors, it is related to the development of polycythemia, blood transfusion associated necrotizing enterocolitis, sepsis, hypotension, or asphyxia. Another question, what are the role of risk factors previously described for NEC as a maternal disease, whether toxemia, infant course like asphyxia, PDA, and type of management like the if the baby is having umbilical arterial catheter. So the enteral feeding, it is if we are giving the mother own milk, this is protective for the necrotizing enterocolitis. Hyperosmolar formula or medication should be avoided. Formula feeding lacks the immunoprotective factors and will lead to the development of the necrotizing enterocolitis. Asphyxia is a factor for necrotizing enterocolitis, but umbilical arterial catheter is not. The question now about you are in the NICU taking care of preterm when the nurse says she thinks the baby has necrotizing enterocolitis. So what are some of the signs and symptoms that will lead to suspecting the necrotizing enterocolitis? It is the onset, as we mentioned, it is later in the preterm babies, earlier in the term babies. The physiological signs that like the temperature instability, apnea, episodes of bradycardia, desaturation, lethargy, and the physical signs that like the feeding intolerance, increase in the gastric residue, abdominal distension, ocal blood, peritonitis, discoloration of the abdominal wall as we have seen earlier. And finally, we do the X-ray to see the staging of the necrotizing enterocolitis. So who is waiting to see the staging of the necrotizing enterocolitis based on the X-ray? No one. Why? Because very important point that the bill classification of the staging doesn't always ring in time. So mostly it is later than the disease itself. So here we're coming to the الحكيم اللي احنا اتعلمنا منه ان هو اذا معايا عصاية واحدة ممكن اكسرها, and if I'm having a bunch of sticks it will be difficult to crash it. And from here came the idea of the bundle, and now you will be hearing more and more about the bundle in the NICU, and it is a group of evidence-based intervention related to the disease or care process that when executed together result in a better outcome than when implemented individually. Bundle, it is not a one-man show, it is a full team process, and it is based on the evidence. It needs the multidisciplinary approach, and most important, it needs a leadership intervention for the best results. So the necrotizing enterocolitis scale bundle was developed in UK and based on some old ideas and the new ideas. The old ideas were when we started the neonatal, at least my residency, we were having fear of the necrotizing enterocolitis, so we were delaying the enteral feeding, rapid feeding of the baby. We were not encouraging. We were giving the formula versus the human milk thickeners. We can use the aggressive and random transfusion, antibiotics. But what is the new ideas is the initiate early trophic feed as early as the first day of life, even at as early as the first hours of life in the latest guidelines for the golden hours, advancing of the feeding over 1 or 2 weeks maximum in the preterm babies, the human milk to be used, consider pasteurized donor milk, and this will come to discuss because now it is coming to our region, although we were having a suspicious earlier as a religious issue. But I think the Saudi Arabia have approved it because it is not from one mom, so it is approved already in our region. So we'll be hearing more and more about the pasteurized donor's milk. We will hold the feeds before and during transfusion, the potential contributing factors for the neck-free NICU, and this is another statement that we'll be hearing with the bundles, that neck-free NICU, CLABSI-free NICU, ventilator-associated pneumonia-free NICU, all this by the use of the bundles. In the bundles, we are having the kangaroo mother care and how it improved the care for the baby, the mothers, and even the incidence of necrotizing enterocolitis, and the KFC, which is the not Kentucky Fried Chicken, but it is the kangaroo father care. So father can also have the kangaroo father care with the baby, with the good psychologically impact for the parents and also for the baby during the hospital stay. They have mentioned that the hospital stay is much less with the kangaroo care. So the neck bundle, they aim to reduce the incidence of necrotizing enterocolitis using mainly the mom's own milk. We discussed it is multidisciplinary team representing the whole neonatal intensive care unit. There are many factors that will help in reducing this, and many points were considered when they started to implement the bundle, and they ended in the first stage by 4 final elements, with the early promotion of expressed breast milk, ongoing support of the expressing breast milk before up to discharge, following standardized enteral feeding guidelines. And here I want to mention that each unit should have its own guidelines, rather than having an internationally agreed guidelines which is not fitting to our unit. So each unit should tailor the guidelines based on the setup of the unit. This where اللي هي pamphlets that were giving to the parents and the doctors. This is the algorithm and the pathway, and the bundle showed that there is improvement in the necrotizing enterocolitis. It reduced the necrotizing enterocolitis in UK, and now they are increasing their database to involve other centers. I will have another 2 minutes if you allow me. The necrotizing enterocolitis seen increasing nationally and internationally beyond UK. It is for the breastfeeding. It is not related to the new culture. It is since old cultures. It is in our Quran where in Surah Al-Baqarah والوالدات يرضعن أولادهن حوالين كاملين. The breastfeeding is prebiotic, probiotic, symbiotic, and love biotics even since long ages. To prevent seeing this picture, we have 2 talks about the probiotics, whether it will prevent the necrotizing enterocolitis. Yes, for the term babies, but for the preterm babies, we should have the specific necrotizing enterocolitis probiotics. And I think here we're having so many studies done in Ain Shams University. Dr. Hisham Awad was Professor Joseph No. He's having a publication about the use of probiotics, اللي هو اللبن الزبادي. Probiotics will have a benefit in the low and income and medium outcome countries. You can see here that the forest plot for the effect of probiotics on the necrotizing enterocolitis. It reduced the enterocolitis, it reduced the late onset sepsis, the all causes of mortality. And here what we discussed about the pasteurized donor's milk. For the sake of the time, I want to conclude that the human milk is the level of evidence one with recommendation grade A that will strongly benefit for reducing the necrotizing enterocolitis. Also, we are having the feeding advancement, the fast feeding advancement versus the slow are safe, both are safe. And the effect of osmolarity, we can see that it can cause mucosal damage when we use the hyperosmolar milk or the fluids or medications. We are having also the feeding and mortality. Does the length of antibiotics? Yes, length of antibiotics, although it is low evidence, but will help in reducing the incidence of necrotizing enterocolitis. Here are my references. Looking forward seeing you in our conference, 13th International Arab Neonatal Care Conference that will be in Dubai last weekend of September. And thank you very much.
Thank you دكتور خالد. يعني as usual far beyond كل حاجة يعني وموضوع very very important وtopic